Okay, thank you very much to the organizing committee for the kind invitation to participate in this wonderful meeting. My topic is a new TAT system that is based in the anatomy. I am a surgeon and an orthodontist, so I have both views, and the idea is to try to solve all the problems or many of the problems we have as orthodontists or as surgeons in our daily practice. I'm professor at CES University in Medellin, Colombia, and I'm also doing some research work with Dr. Flavio Uribe and Dr. Nanda in the University of Connecticut, and we are also working together with Dr. Peter Buchang from Baylor College of Dentistry, and I want to thank them for their support. This is my family. I always thank them for their support. This is my wife, Eliana, my daughter, Rosario, she's 11, and my son, Cristobal, he's 8. This is my disclosure. I'm not interested so far to make money with this development, so my only interest is to help my patients in the daily practice. Main problems we have working when we deal with mini screws in my practice are we have some failures and soft tissue irritation around the mini screws. So to try to solve those problems, we designed this type of mini screws. Some of them are short and some of them are very long, as you are going to see. And they have threads on the tip. This is a self-drilling mini screw, and it has a smooth neck to improve soft tissue healing. And it has a bracket head with 2 slots, and a slot on the top and an extra slot on the neck in order to use cantilevers or auxiliaries to have some biomechanic options in our cases. So with regard to the soft tissue healing, we can see this is a mini screw, it's 20 millimeters long, and when we go out the alveolar bone, the alveolar process, we have to use longer mini screws, and it is impossible for them to emerge through the keratinized gingiva, so they have to emerge through the mucosa, and this smooth neck is going to help to the amazing soft tissue healing that you can see here. This is a 35 millimeter long mini screw that I place in the zygoma, and you can see the soft tissue healing in this area. And this is an infrazygomatic 25 millimeter mini screw, and you can see the soft tissue healing around the mini screw, the smooth neck. I have used for temporary replacement. This is a patient that had the permanent lateral incisor canine missed, and I'm going to replace this deciduous canine with a temporary implant. Then I extracted the tooth. I placed the screw into the alveolus. It could be flapless, or you can make an incision to be sure to be into the bone. Then this is the mini implant in position. I add some composite on the top. Then you can see after 2 weeks the soft tissue healing around the provisional crown. And this is the screw. I'm waiting to see what is going to happen with the alveolar bone here, because with this smooth part, I'm waiting to see that the alveolar bone is going to grow normally. And this is the case 2 years later. You can see the soft tissue healing here. And if we compare 2 weeks later, and then 2 years later, we changed the provisional for a longer one, but the soft tissue healing is very nice. So it's been reported that we have on average 13.5% of failures, and the numbers are from 0 to 40, as reported in this meta-analysis. What I have seen is when we go to the alveolar process, the number of failures are closer to 40 than to 0. And when we have a failure in our practice, we have to change our treatment plan. Then we start wasting time and money. Our reputation and credibility is affected negatively. And we become kind of frustrated because we have to change the original plan. It's been reported by many authors that the quality and quantity of bone in the alveolar process is not the best bone to place mini screws. The alveolar bone has low density and the thickness of the cortical is low. And also, root contact and close proximity to the roots are well-known risk factors for mini implant failure. So I have been following Dr. Chris Chang. He's a wonderful speaker and a wonderful clinician, and in part of his philosophy is to go outside the roots. I agree completely with this mini screw that he is using in the mandibular buccal shelf, but I have had some failures when I use this, he calls on many authors, called infrazygomatic, but this is a supra-alveolar because they go this way, or lateral alveolar mini screw. If we want to go infrazygomatic, we should go to this area that has a very good quality and quantity of bone. We can go, as we can see here, 4 millimeters inside the bone, and we can apply really strong forces. But if we need more stability and to apply higher forces, then we should go to the zygoma. This is a 10 millimeters part of the screw inside the zygoma, and it's a wonderful anchorage, as you are going to see. So we did this anatomical study with Dr. Miguel Ordóñez from Colombia, who is here. And we analyzed these areas, the zygoma bone, the mandibular symphysis, and the mandibular buccal shelf, because I think those are the best areas with the best quantity and quality of bone around the alveolar process, out of the alveolar process. But when we see, I don't have time to show all the measurements, but if we see this distance from the CJ in the first molar, we can see that this measurement on average for males is 41 and for females were 43 in our study. So we need longer screws to go to that area. The idea came from the implants we use, the zygomatic implants we use in prosthetic dentistry. As you can see, if we use 2 zygoma screws and 3 or 2 conventional implants, we can have a fixed total prosthesis, and the implants are going to support the masticatory load. And the amount of bone is so generous that we can put 2 zygoma implants on each side, and we can have a fixed prosthesis. If we see the mandibular symphysis, it has a great amount of bone. The thing is that if we want to place the head of the mini screw in this area, we need longer screws than the commercially available today. The average is 34 millimeters for males and 31 for females. And same thing for the mandibular buccal shelf. We have these numbers, 19 and 17, so we should use, to have a great anchorage, longer mini screws. So we designed the whole series from 9 millimeters to 40 millimeters with the smooth neck, all of them, and the diameter is 2 millimeters. So we have the whole options to go to everywhere around the alveolar process. The name is called LOMAS VEGAS. It's from the fabulous Las Vegas sign. And the last we changed for LOMAS, that is the original name. We developed these mini screws with Mondial. It's like Arno Fritz. It's a company from Germany. And then this is the name. And this is my last name, but it's a modification of my last name, that is Villegas. Then we have this name. The shorter ones were designed to be used between the roots and in the palate, 9 and 11 millimeters. The medium size were designed to be used on the mandibular buccal shelf and infrazygomatic. And the longest ones were designed to be used, the 25 and 30 millimeters to be used in the mandibular symphysis, and the 35 and 40 into the zygoma. I have been using mini plates, I think, and it was reported by Shuttle and coworkers that the mini plates has the less failure rate compared to another kind of mini screws. I like very much to use mini plates because it's a great anchorage. And we, 8 years ago, when we started doing surgery first, we used Dr. Sugawara mini plates to distalize the whole maxillary arch, and we can use also in the lower to distalize the whole mandibular arch using mini plates as anchorage. And we did these cases. This is the overjet pre-surgery. The overjet we had post-surgery, and you see that we need to distalize the whole maxillary arch in order to have this result in 7 months. It's a short period of time. The problem when we see the mini plates, we have some problems using them. We have some failures, and we have to do 2 surgeries, 1 surgery to place them and 1 surgery to remove them, and the cost is high. So we decided to do this split mouth study with 10 patients. All of them were surgery first patients. And then we compare the mini plate, the stability and comfort of the mini plate with the zygoma screw. This is one of the patients it's a pilot screw. This is one of the patients. She was a class 3 with a maxillary deficiency, mandibular prognathis, some mandibular deviation to the right, moderate crowding in the upper and in the lower. We can see the panoramic X-ray, nothing important. And she had a compensation, buccal inclination of the upper incisors and lingual inclination of the lower incisors. So the PA, this is the prediction I did for maxillary advancement and mandible setback. Moral surgery, I was planning to leave 5 millimeters overjet in this area, positive overjet, so I need to distalize the whole arch anchored in the mini screws and the bone plate. This is pre-surgery. We place the brackets. This is the bone plate on the right side and the zygoma screw on the left side. The occlusion after surgery is very important to use class 3 elastics. I don't use splint, as Dr. Sugawara said in his protocol this morning. I just don't use the splint after surgery. I leave the teeth start moving. Then it's very important to use class 3 elastic, and we can use the skeletal anchorage to use the class 3 elastics. This is 2 weeks after surgery. The overjet, we have to keep this overjet in order to solve the crowding in the lower. The lateral ceph and the panoramic, where we can see the bone plate and the zygoma screw. This is 6 weeks after surgery. Then we are making the space with this expansor here for the lower canines and the overjet that we maintain. And then I start distalizing the premolars anchored on the bone plate and the zygomatic screw. Then this is 4 months after surgery. You can see the overjet. We are having an edge-to-edge anterior relationship. So I went to the lower arch and I placed these 20 millimeters mini screws on the mandibular buccal shelf in order to distalize the whole arch with the coil springs. This is 6 months after surgery, 2 months after placement of the screws on the mandibular buccal shelf. We can see the space here that we have in order to manage the overjet, and now is much better. This is the healing around the bone plate and around the screws. You can see that there's no much inflammation around the screws. And this is the panoramic X-ray where we can see the screws on the mandibular buccal shelf. The occlusion, 9 months after surgery. The overjet, this is 12 months. And this is when I finished 17 months after surgery. The upper and lower arches and the overjet. This is the profile after surgery, the smile, after debonding, and the follow-up to 17 months. Frontal view, the smile, and the occlusion, the sequence. The overjet. So what the results with this study were, it took me double of the time to put the mini plates compared to the screws, but this is not clinically significant. Regarding the stability, we had 100% stability in both sides with both systems. And regarding the discomfort, in the VAS scale from 1 to 10, we had a little more discomfort around the bone plate compared to the mini screws. Both groups had some kind of discomfort, but it was higher in the bone plate side. So our conclusions are both systems were 100% stable, but the zygomatic screws have some advantages related to comfort, and they are easier to remove than the bone plates because you just have to unscrew and that's it. I have been following Dr. Hugo de Klerk. He's a wonderful speaker. He has been working very enthusiastic with this technique, doing orthopedic treatment for class 3 growing patients. But if we compare the system with bone plates with the just screws, you can see some advantages using screws. The first one is we just need two surgical sites instead of 8 because the only incision we have to do to place these screws is in the zygoma, because to take them out you just unscrew. The screws, they are a stronger anchorage compared to the bone plates, and age is not a problem. Dr. de Klerk has advised not to use this system before 11 years in girls and 12 in boys for 2 reasons. The first one is that the bone plates can come loose before that age, and the second one is that we can harm the germ of the canine, the permanent canine, if it hasn't erupted yet. With the mini screws, we don't have that problem. We can use these screws at an early age, and we don't have problem with the germ of the canine because we can incline the screws to the mesial. So this is a patient with a mid-face deficiency. I did surgery on his sister 2 years ago. Then he came to my office. He had this edge-to-edge anterior relationship, class 3 canine in both sides. It's like the deviation of the lower midline to the right. I checked with the bone scan, but I couldn't confirm an active condylar hyperplasia on the left side because the uptake was increased on the right condyle. So there was no problem. He had previous first premolar extractions by the pediatric dentist in the upper, but not in the lower. This is the panoramic X-ray and the lateral ceph, where we can see that the incisors has no compensation. So I place these screws in the mandibular symphysis and in the zygoma area. We can see in the panoramic X-ray how we can incline to the mesial the mini screws in order to avoid the germ of the canine in a younger patient. If we see the CBCT, we can see the great amount of bone of the screw that is into the bone in the mandibular symphysis, a great anchorage, and also in the zygoma. We can see 10 millimeters of the screw inside a solid bone in the zygoma. So we can use this force. Dr. de Klerk has advised not to use more than 150 grams for this therapy. And the reason is that the bone plates in the zygoma can come loose with stronger forces. But with this, I am using here 300 grams on the right side and 600 grams on the left side in order to try to solve the lower midline problem. This is the healing around the screws. It's not perfect. He doesn't have a perfect oral hygiene, but he doesn't have discomfort. This is the result, the projection of the mid-face, the occlusion, the change in the occlusion, and the overjet. And we can see before and after the projection of the maxilla and the improvement in the occlusion with these forces. I have used also, this is a very common problem when we lost a first molar at an early age. So I was distalizing in order to place an implant in this area. But when we mesialize the molar, most of the time we have a tipping of the molar. When we pull the crown forward, the crown inclines to the mesial. Then I review the CBCT. When we go to the premolar area, we don't have a buccal shelf. The buccal shelf, in most of the cases, is in the second molar area, but when we go forward to the first molar or to the premolar, we don't have that buccal shelf. So we have to go to the buccal plate. The problem is that we have 19 millimeters, so we have to use a longer screw to have true anchorage to do all the to apply all the force I need for this case. Then I place the mini screw and I use this rectangular arch wire with this loop in order to mesialize, and I apply an anti-inclination bend in this portion in order to mesialize the molar. And this is such a great anchorage that we can use a power chain in order to avoid rotation of the molar with this lingual button. And then we can see in the X-ray how nice is the bodily movement of the molar with this system. And this is at the end of the mesial movement. We can see it's aligned, no tipping of the molar, and there is no rotation. This is the last case I'm going to present. I have been treating this type of patient. She has a facial asymmetry. She has an active condylar hyperplasia on the right condyle. And I have been treating them with bone plates to help with the skeletal anchorage. We can see the lower midline deviation to the right. The panoramic X-ray, we can see a longer condyle on the left side compared to the right side. And we ordered the CBCT, the CT scan, sorry, in order to check the canting of the occlusal plane, to see the mandibular deviation to the right, and we can see a longer, bigger condyle on the left side compared to the right side. So I was planning to do a condylectomy in this case. Let me see the pointer. Oh, yeah. I'm planning to do the condylectomy. I recommend to cut as much of the condyle as you need to center the lower midline. So I planned that on the CBCT, and I placed the zygomatic screws in order to have a skeletal anchorage and some screws on the palate. Then you can see how the occlusion is worsening. It's like if we had a condylar fracture. Yeah, then we have this huge overjet. You have the midlines are on right now, and we have almost a Brody bite on the right side. Then I started intruding on the left side, the molars, in order to correct the canting of the occlusal plane and from the buccal and from the palate. Then I am intruding both sides in order to intrude the molars, both sides from the buccal and from the palate here, in order to allow the mandible to rotate anteriorly and to correct the overbite. Then once we corrected the overbite, then we are distalizing the whole maxillary arch in order to have class 1 both sides. This is the case after distal movement. Now we are setting the occlusion, and this is the final result. Then we build up the incisors, and this is the patient at the beginning, after condylectomy, and then the final result without orthodontic surgery, just managing with condylectomy and orthodontic therapy with the mini screws therapy. This is the smile after treatment and the follow-up. The profile, you can see that she had a slight class 3. She had been treated with a face mask before, but then the profile is better because the mandible went back with the condylectomy. And this is the occlusion at the beginning, after the condylectomy, the malocclusion, and then when I was leveling the canting of the occlusal plane, and then intruding both sides, and then distalizing, and then when we finish the case. This is the Archimedes point. Give me a lever long enough and a place to stand, and I can move the world. If Archimedes were alive today, probably he would say, give me a LOMAS VEGAS and I can move the world. Thank you very much.
Return the mic back.
Yeah. Okay.